A very good evening to all the PG aspirants. I am Dr. S. Ganesh Ram. I am an orthopedician and now we are going to discuss about orthopedic oncology. So orthopedic oncology is one of the favorite topics for the examiners. So usually you will get a question with the age, with the gender and certain clinical features of a particular or oncology condition along with an X-ray, and you will be asked to arrive at a diagnosis. So this is the question frame: age, gender, the clinical features, that is pertaining to the local features pertaining to the bone, whether it is femur or a humerus. So pertaining to that part of the bone, you will have some local clinical features, and there is also some systemic features associated with certain malignant tumors also. So those things also will be given as a clue in your question. And finally you will have an X-ray image. For example, so this is a sample question. A 20-year-old male complaining of pain and swelling over the lower thigh. He is also having difficulty in walking. So he has fever, anemia. So this is the X-ray picture of the patient. What is the diagnosis? See here, the age 20 is given. So certain tumors are most common at the age of 20. So age specific tumors you have to know. Then male. Certain tumors are predisposed to the male and certain tumors are predisposed to females. Those things also we have to know. And see, there is a pain and swelling over the lower thigh. This is the local clinical feature pertaining to that area of the bone. And there is also a fever and anemia. So these are the systemic features of this particular tumor. So this is the X-ray picture now. Now what is the diagnosis? See, sometimes you might not know the age specificity or the gender specificity. Sometimes the clinical features will overlap. So if you have some confusion over there, this X-ray picture, you have to properly read the X-ray to arrive at a proper diagnosis. So just with the X-ray you will have some spotters also may be possible. Just with the X-ray you can arrive at a diagnosis. So this class is going to be how you are going to read the X-ray, how you are going to differentiate between a benign and malignant lesion, and then you have to correlate that with the specific site of the lesion and specific bone along with the clinical features. All you have to combine. Finally you have to arrive at a diagnosis. So this section we are going to deal with how we are going to read an X-ray. So you have to remember this mnemonic: numerous student, parent meeting cancelled, coming metro PlayStation. So this is the mnemonic. So the numerous here, N stands for the name of the bone, S for the site of the bone, P it means a pattern of destruction, how the tumor has destroyed the bone, and here this is the margin. So the tumor margin. Then here cortex and medulla, how it is separated. Here the cortex is whether it is present intactly or it is destroyed. The matrix, how is the matrix, the stroma of the lesion. Then is there any periosteal reaction or not? Is there any soft tissue extension or not? All these things you have to take into account in order to read the proper X-ray and arrive at a proper diagnosis. So for example, if any lesion, so this is the bone. For you know that there is a multiple myeloma is a condition where you get a punched out lesion of the skull. Then distal femur, proximal tibia, most commonly you will get a osteosarcoma, osteoclastoma. In the phalanges you get enchondroma. So similarly, some tumors have a specific location of the bone. Some tumors are most commonly present over certain parts of the bone. So those things we'll be discussing in the separate headings. So this is the thing. A bone which is specific to a particular tumor, if you know that, you can pinpoint to a diagnosis with probability. Okay. Next, epiphysis and diaphysis, and then this is a metaphysis. So certain tumors are present over the epiphysis, certain over the metaphysis, and certain over the diaphysis. There is some overlap also that we'll discuss. So you need to remember this mnemonic. This is the most common lesions of the particular part of the bone. So here this is the diaphysis. D for diaphysis. Demo ECG. Remember this code word. D for diaphysis. Ewing sarcoma is most common over there. M for metaphysis. Osteochondroma is most common over there. E for epiphysis. Only two lesions are usually there. This is chondroblastoma and giant cell tumor. Most of the tumors they arise from the metaphysis. So if you are not sure of any tumor where it is origin, so you can know probably 80 to 90% of probability that it is arising from the metaphysis. But this mnemonic you have to remember, because this is particularly from this part of the bone only these tumors will arise. Diaphysis Ewing sarcoma, metaphysis osteochondroma, epiphysis chondroblastoma and giant cell tumor. Okay, this is the demo ECG. This is the mnemonic. So these are the various types of tumors and their locations. See, most of the tumors arise from the metaphysis. Even the osteoma, it comes in diaphysis, and it can also occur in the metaphysis also. Fibrous cortical dysplasia also, it can arise either in the diaphysis or in the metaphysis. Okay, so some lesions may overlap. Next, a pattern of destruction. There are three patterns of destruction. So this is the first one, is a geographic pattern of destruction. You see, this is a map of India. Each state has a specific specific geographic pattern. So this is the proper pattern of the state. This is the proper pattern of Tamil Nadu. So same way, the tumor inside the bone will have a specific pattern. So if that is the case, then it is called as geographic pattern of destruction. Second pattern would be a moth-eaten pattern. See here, the multiple moths, they are eating the leaves here. You see the shape of the leaves. See, it is how it is very irregular. So this is called as moth-eaten pattern. This is the geographic pattern most commonly presents with the benign tumor. Moth-eating pattern, you can remember the mnemonic moth-eating leaves. M for metastasis, E for Ewing sarcoma, L for lymphoma. Okay, so these three most commonly present with a moth-eaten pattern. Next one, permeative pattern. So permeative is a diffuse spreading. So see, starts from one region and diffusely spreads through several regions. This is called as permeative pattern. So this classification is called as Ludwig's classification. He has differentiated the tumor destruction of the pattern based on the shape, either into a geographic pattern. See, a proper border and margins are present here. This is the moth-eaten pattern. See, there is a normal bone is present in between these segments, moth-eaten segments. See, this is the permeative pattern. Very diffusely it's present. Next, margins of the lesion. You see here, the lesion is having a well-defined margin. Can you able to see the dark white border? You see, so this means this tumor is properly well defined and the adjacent normal bone is clearly visible. Whereas here, you see here, the border and the margin is not clearly visible over this part. It means the tumor is aggressive, it is growing onto the normal bone and there is no margination or capsulation is present, which is indicated towards it is a malignant lesion. Okay, this would be a benign tumor. Then next point would be corticomedullary delineation. You see here, this is the cortex and this is the medulla. Clearly we can delineate. Whereas here, the cortex here is smudgy and you can see here, both the cortex and medulla we cannot differentiate properly. You see here, see this is a cortical border and here is the medulla. Whereas here, the cortex and medulla, the delineation is lost. So this is the suggestive of malignant lesion. See here, cortex, whether it is intact or breached. You can see here, the cortex is continuous. And this is the lesion. This lesion, once it grows, it thins the cortex. You see here, the cortex has become very thin and the lesion has grown. but still there is no breach in the cortex. We can clearly see the cortex. Whereas here, the cortical line is not seen, which means the tumor has breached the cortex. This is a classical example of, this is classically the giant cell tumor. This is the phase 1, 2 and 3. Okay. Now, we go into the matrix of the lesion. You see here, this is a homogeneous matrix. This is the lesion. It's very homogeneous with the central dot here. This is called as nidus. It is very classical for osteoid osteoma that we will discuss under when we are dealing with the individual tumor sections. Okay. Look at here. See here, there is a hypodense lesion. Here is a hyperdense lesion. So, and here is again hypodense. Here hyperdense. So the density of the lesion changes within the lesion. This is called as heterogeneous matrix. Okay. So this is mostly suggestive of a malignant lesion. For example, in chondrosarcoma, you will have popcorn kernel calcifications. That will have the popcorn calcification will be a dark white color. That's a higher density, hyperdense. The surrounding matrix would be a hypodense, which appears slightly black. So there will be a difference in density there. That's called popcorn kernel calcification seen in chondrosarcoma, which is a malignant lesion. So similarly, each tumor will have the density of the matrix changes. If it is a homogeneous density, it is mostly a benign, and if it is a heterogeneous density, it could be a malignant lesion. Next one, periosteal reaction. So there are two types of periosteal reaction. One is the solid periosteal reaction. These are interrupted periosteal reaction. You can see the periosteal reaction is continuous here. Here the periosteal reaction is interrupted. See there, several lines are there. It is not continuous line, it is interrupted. One line is here, one line is here, one line is here, and it is an interrupted lesion. So solid lesion, mostly it will be a benign. There are some exceptions, and these interrupted lesions are malignant. All interrupted lesions are malignant. Okay. So each tumor will have a specific periosteal reaction, which will be discussed under particular tumor headings. Alright. The next would be a soft tissue extension. Here, the bone lesion is within the bone, and there is no connection with the soft tissue. Whereas here, the bone lesion is extending into the soft tissue, which means it is going for a metastasis. So it is a malignant lesion. This type of lesion will have systemic features, not only local feature, but they will have systemic features also. Okay. So these are the basics on how you read and radiological features of a tumor. Now we go back to the question. So 20-year-old male complaining pain and swelling, lower thigh, difficulty in walking, fever and anemia. So he is having systemic features, local features, and the age group is pertaining to a certain tumor, and gender also points to certain tumor. Now, based on all the radiological findings we have discussed so far, let's discuss here. Just certain points. If you are not able to remember all the points, just remember some points to so that you can correlate with the question. You see here, this is the lamellated pattern of periosteal reaction, first one. And you can see here, see there is a medulla is here and the cortex is here. You can clearly differentiate in the upper part, whereas in the lower part the cortex is here, see, but the medulla, it is not as clear as the above. You see here, the medulla is not clearly marked, so the corticomedullary delineation is lost. And you can see here the periosteal reaction. This is the hair on end appearance. It is an interrupted periosteal reaction. Here it looks like a onion peel reaction. So the periosteal reaction is interrupted, which is pointing towards a malignant lesion. And the corticomedullary delineation, that is also lost. There is no breach in the cortex that is clearly visible. Okay. And the soft tissue extension. So this is, you can see here, slight shadow outside. This could be a soft tissue extension. So these features point towards a malignant lesion. So this is a case of malignant lesion. So which malignant lesion is most common in 20-year age and presence at the shaft? Obviously it is a Ewing sarcoma. So even if you don't know why the fever anemia occurs here, if you are forgetting all the other features also, just with the radiological features, the site of the lesion and the periosteal reaction, all these findings that we have discussed in this class, with those findings you can arrive at a proper diagnosis which will be correct most of the times. Okay, so that's how you have to read an orthopedic oncology question. Alright, in the future upcoming sessions we will discuss each tumor and how each tumor presents and how will be the radiological picture. All these things we can discuss in the further classes. Okay, thank you very much.